So the Verdun systematic review tells us that these things have been important to patients in hospital and families for a number of years now. Shared decision-making, treated with compassion and respect, good symptom management, people's concerns heard and acted on. My own work takes this a bit further in terms of safety and quality. So the obverse of safety and quality is iatrogenic harm. That's usually thought of in terms of the wrong medication, falls, infection control. That's all still important to people, even in the last days of life. But what is also important to them is emotional safety, spiritual safety, social safety, having familiar things around them at the bedside. The most critical thing, I think, is treating someone as how you would want to be treated yourself, and how you would want your mother or your father or your son to be treated. Responding to people, recognising that they're out of their familiar environment, and making them feel at home. I think listening to people. Paul Crawford and a colleague has some great work around fast healthcare, where people don't expect you to sit down with them for hours on end, but it's in the moments of when you are with that person and how you relate to them and respond to them. So whether that's taking the blood pressure or taking someone's bloods or explaining to them on a ward round, doing that in a way that respects and values another human being. And there's some great work in the UK by an activist who is a patient as well as a doctor. And it's very simple. My name is. So often we don't introduce ourselves and explain who we are and why we're there. My name is Aileen, and I've come to check your blood pressure. We're so busy running around that sometimes we miss the cues. Often patients and families themselves know what's happening. We're often worried about what to say to them and how to say it. I would say that we need to be less worried about what we say and more worried about how we be with people.